Right. Well, thank you everyone who is here on time. We appreciate you all being here today. Um, you might have seen me in some prior project echoes, but my name is Ruru Wang, and I'm a geriatrician also over here in Seattle, working alongside Kate, and I am stepping in today to help with today's session. So without further ado, we have a fantastic speaker today, Emily Trittschuh, who is a neuropsychologist at the VA and Associate Director of Education and Evaluation at the Geriatric Research Education and Clinical Center of the Puget Sound VA. So I'll let her go ahead and get started.
Thank you so much for having me. I really love this venue because it pushes my edges, having to try to really focus on the pearls of a topic rather than talking at length about something. So, my goal here is to present what would be very usable for a broad sort of frontline care audience of different professions about the topic of mentation and specifically within mentation dementia. So, just in case not all of you are familiar with the Age Friendly Health System Initiative, there are four pillars to this framework, which at its main goal is to provide, not surprisingly, age friendly healthcare. The four pillars are listed here. Today, I will be focusing on one component of mentation. You can see here under the description of mentation, it's prevent, identify, treat, and manage dementia, depression, and delirium. And that's across settings of care. So you can imagine that's actually pretty broad, as well as when we think about dementia across quite a range of stages of that individuals might be in while experiencing dementia. I do want to call out, though, that this little graphic does not really go beyond depression in terms of mental health conditions. So while I go along and especially for me working at the VA with my clinical care, I always want to have people keep in mind that depression is not the only mental health condition that can affect mentation. We can think about things like anxiety, PTSD, many others as well. So don't lose sight of that, please. Okay, so today, mentation and aging, it does compose both sort of cognitive function as well as mental health. Those three Ds that were on the page before, depression, delirium, and dementia, are important to have in mind when we're working with older adults. We might want to think about what are some of the typical changes that we might see in aging, though, before we decide what might be more indicative of atypical changes. So, in terms of typical cognitive aging changes, these are data, older data from the Seattle Longitudinal Study of Aging, so a local lifespan and longitudinal study. It's an older study. Some of the categories they have here may seem esoteric to those who know sort of more common current neuropsychological parlance, but basically the take home message here is that many aspects of thinking, these warm colored lines, are preserved across the lifespan, even increasing after one's 20s, while other things like processing speed, working memory, really do have a decline across the lifespan. Now, this scale that you're looking at here of Z scores makes it look like it's really dramatic. This is not that dramatic. These are very subtle changes. But what I think I see a lot clinically, especially for early stages of concerns about thinking, about mentation, is people coming in this crossover zone, maybe like 50s to 65. And those can be some of the toughest cases to sort of figure out, well, what do I do next? Keep in mind that normal aging should not include people having losses of their own autobiographical information. They shouldn't be losing knowledge of well learned information. Procedural memory should stay intact. Emotional processing should stay relatively preserved as well. But as I mentioned, people may have more trouble with processing speed, working memory, maybe a little slower to encode new information. The reason we care about typical changes is because not all changes are always benign, right? So here's this normal aging across the top. Everyone experiences a little bit, some more than others. But then we want to think about if the changes are no longer typical, beyond what's typical, we have concern then for what's sort of considered sometimes an interim stage of mild cognitive impairment. That's what the MCI stands for, and or dementia. And either it's mild, moderate, or progressed beyond that stages. I'm going to now, in a second, tell you sort of how do we distinguish clinically what are the the reasons that would say that there's a difference between those. Okay, these are the things that I hear in clinic, and you would likely hear in your clinic spaces as well. I won't read through all of these, but the main thing I would say is that all of these could be a red flag for dementia. Not necessarily a one-to-one, for sure it's dementia, but there's certainly something to pay attention to. They are red flags. So, when we want to define dementia, we need a few critical criteria to be in place for this clinical syndrome, right? There needs to be a decline from someone's baseline, whether that's their lifelong baseline or a baseline that's newly established after, say, a head injury in their 20s or maybe a stroke in their 50s. But there needs to be a decline from that baseline in some aspect of their cognitive thinking abilities and or maybe a particular type of behavior. The changes have to be significant, meaning there has to be a functional consequence. There's some loss of independence as a result of the cognitive change. If someone has a stroke and they lose some motor function, that would not then necessarily mean that there's a dementia, right? Also, dementia is chronic. It typically has an insidious onset, and unfortunately, the course is progressive. It needs to be a loss. If someone has lifelong had a reading disability, we would not say that their reading impairment is a marker for dementia. So, this is why a nuanced workup sometimes has to happen, not always, though. In terms of what's going on in the brain, there is structural damage occurring if the dementia diagnosis is being properly applied. Neurons are dying either from vascular insufficiencies or changes or from actual protein pathologies in the brain, like the two types of pathologies we associate with Alzheimer's disease. Okay. Dementia is not, this is cheeky of me, but it's not delirium and it's not depression. Those are the other two of the big three Ds. That isn't always easy though to determine, as they do have some overlap. I'll comment on that later. We want to be really careful that we don't ding someone for what is a sensory deficit or a communication problem. I mentioned earlier, someone might have had a stroke. They may have a sequela of aphasia due to that. Their trouble then with verbal production or some aspect of their language abilities should not, it has to be sort of teased out from what other changes might be going on that could suggest there is also a dementia process. Dementia is definitely not normal aging. Could we all develop dementia if we lived long enough? That's a question we don't know the answer to, but we certainly know that many people who live into their 90s and hundreds are cognitively intact and able to live independently. So we should not just think that this is something that's inevitable with aging. I have highlighted here a few different types of dementia. I have Alzheimer's dementia, Alzheimer's type dementia first, because as far as we can tell, and all the research supports that it is the most prevalent cause of dementia in aging. The next one is vascular dementia. And third on the list, at least in United States populations, is Lewy body type dementia. I include Parkinson's disease with dementia here because I think, given how many challenges the motor symptoms of Parkinson's disease, and I say motor symptoms, gait symptoms, motor symptoms, postural instability, it can be forgotten that unfortunately, as people age with Parkinson's disease, and then especially if they've had the disease for, say, 10 years or more, their likelihood of developing a dementia syndrome that goes beyond just the pure Parkinson's triad and other associated symptoms is incredibly high. So, keeping an eye and monitoring folks with Parkinson's disease for that is important. Frontotemporal dementia in aging over age say 70 is less common. However, it is often results in different behavioral or judgment changes for the individual. Under age 60, it is about half and half as common as Alzheimer's type pathology as the cause of dementia. So it's useful to have that term in your lexicon when you're thinking about types of dementia and what could potentially be going on. So I have here these top three prevalent causes. Just keeping in mind, dementia and like vascular dementia, Lewy body, these are clinical terms, and we're saying it based on a fairly strong belief, often without some sort of invasive cellular review, that it's based on a neurodegenerative disease process. In vascular dementia, the underlying disease process are cerebrovascular changes and pathology in the brain. For Alzheimer's disease, it is two different types of pathology based on beta amyloid, amyloid changes, and also a tau problem in terms of tau pathology in the brain. For Lewy body disease, the protein involved with that is alpha synuclein as the core sort of pathology. But understanding that we typically, in most clinical settings, are not diagnosing this with those markers as common knowledge. I do believe there will be some clinically available tests soon that use blood to be able to detect the two pathologies of Alzheimer's disease. Those should be probably coming to market at least in the next year or so. But do know, I have my little markers here. These guys overlap. Not everyone has just one. It is not uncommon to have, say, a mixed type dementia where you have both cerebrovascular disease and likely Alzheimer's disease in the brain that are contributing to the clinical picture. And also, I would like to say that despite sort of the media attention, could perhaps call it hype, aggressive advertising and marketing, we do not have treatments for Alzheimer's disease or any type of dementia that actually result in clinical improvements. None of the drugs make people better. Their best claims currently are that they can have someone be with say Alzheimer's disease decline at what they have found and say is perhaps a slower rate. Okay, so we can come back to that with discussion because I think that might be an area that people are interested in more. So clinically, when we're working up someone for dementia, we want to keep in mind that it's a diagnosis of exclusion. So it's really important to think about different risk factors that may be causal or contributing. Here is just sort of a grab bag of some. There are many others. This is certainly not exhaustive. You might notice that depression is on here. You might be noticing that some of these things, like toxic metabolic or other things, alcohol and drugs, could lead to a delirium. So these can also be part of the other D. We want to work on these factors. And the challenge is that even if we identify some of these as potential factors contributing to the changes being seen, treatment may improve them but not fully reverse them. So it's important to kind of keep following people over time carefully. I'm not going to go on to detail this, but you'll have it in your PDF of the slides. It's just kind of a little cross check of some of the features most likely to be associated with dementia versus delirium and depression. Our group has created, at the VA, has created a 3Ds pocket card that has this and other sort of workup initiate information. And we're always happy to share that if someone wants to reach out. Okay. Oh, wait. And I should just say really quickly, just like someone can have a mixed dementia, you actually sometimes end up with these 3Ds, two or more of them superimposed on each other. So it's great if you identify one, but identifying one in a patient does not necessarily mean that you've ruled out the others yet. Okay, red flags. I will not read through all of these because I would never have the time. But at the VA, instead of sort of screening everyone with brief cognitive tests over a certain age, we do use this red flag method. And as you can see here, if you're a clinician, there are many different ways that you might get a red flag. Also, patients themselves or their loved ones, friends, caregivers may report things as well that are red flags. It can be something quote unquote as subtle as, a bunch of missed appointments or showing up for an appointment on the wrong day. That seems to happen a lot. And that could be a red flag. It should prompt the team or a particular provider to step in and initiate a workup. Okay. Let's see. So, initiating workup is really just trying to think about the identification of the red flags, how to screen for red flags, and then what tools might be helpful when we think specifically about dementia. One of the things you remember about what you need for a dementia diagnosis is there is some objective change from people's baseline in their thinking and or behavioral abilities, right? And it's usually in cognitive skills that it's happening. So there's a lot of utility for brief cognitive tests. I want to emphasize, though, that a brief cognitive test is not something that should be used as a standalone measure to diagnose dementia. Okay. However, they are really good for identifying if there are deficits, maybe even to follow someone with deficits over time, potentially identifying cognitive decline or some weaknesses early can help people to address reversible influences or help with care planning, maybe even motivating patients towards, say, positive behavioral change. I've got folks coming in who sort of their drinking ticked upward during the pandemic and they kind of know they should cut back. But when we talk about the onset of their less strong memory and other thinking abilities, it really lines up with that period of increasing drinking and now, unfortunately, far too high. So these are just some of the good reasons that are out there, not just for trying to initiate workup for dementia. So, in terms of brief cognitive tests, the SLUMS was developed at the VA. I always bring that up because it is a free instrument. It cannot be copyrighted because it was developed at the VA. However, it doesn't have as much research behind it or after its development as some others. I do think a good, strong go to is the MOCA, the Montreal Cognitive Assessment Test. It is expected, though, that people will undergo training on how to administer this test so that it's done in the proper manner and the score that's obtained is actually objective. There are other measures out there like the Blessed and the Addenbrook, which also has a US version. I don't get anything from any of these. So just so you know, I'm open to whatever. At the end of the day, using a test versus not using one where you can obtain a more objective marker of where people stand is almost always better than not getting anything at all. Okay. The challenge, though, is to remember that these quote unquote objective test scores might have different meanings or are to be used for interpretation differently in different settings. I've already commented that they are poor as standalone measures. To make a dementia diagnosis, you would need a lot of other input, especially that daily living information, right? Are the cognitive changes actually resulting in a loss of independence? But also think about how folks who might have a learning disability or have low formal education, maybe hearing and vision problems and things like that could additionally have an effect. Now, I've talked about the objective cognitive piece that we need to have sort of in play for a dementia diagnosis to be possible. What was the other piece? Function, right? So there are a number of different ways to measure activities of daily living that are out there. When we're looking at sort of the earlier stages of a potential dementia diagnosis, we're typically thinking about what we call instrumental activities of daily living. So we're not necessarily talking about like transfers, toileting, or feeding oneself. We're usually talking about these things that allow us to really sort of fully engage in our lives. So, unfortunately, at the top is like paying taxes, right? Life, death, and taxes. But being able to engage in fun things too, like playing games, having a hobby, cooking. My dog is in the background barking. I hope you can't hear him. You probably can. And so this is the functional activities questionnaire FAQ. I like it because it's pretty easy across settings to use. The scoring is whether someone is dependent for this item or requires assistance or has difficulty but does by self. They often use compensatory strategies or no assistance needed. I like that they call out, well, what if they never did the activity but could do it now, or never did the activity but would have difficulty now? I think you can already see that this is more reliably filled out by someone who knows the patient well, perhaps than they themselves. But I have had some people certainly can fill this out for themselves. You just kind of wish you had a collateral to kind of confirm it. All right. When we think about health factors, I mentioned some of them before in that slide with different things that can kind of mimic a dementia. But there's also certain things that we want to encourage people we work with to manage, both medical conditions and behavioral factors that can either help them sort of stave off a tipping point to dementia. Maybe it's hard to say that they're truly preventive, but we can say that these things, if done properly, do lead to healthier brain aging. Okay. Well, how did I do? I think I'm right on time here. This is my thank you. You'll have this in your PDF handouts. I want to be sure I put this up there though, because I was asked to add this to the end. And I'm going to leave it up here for a couple minutes, but I do want to stop sharing my screen so I can see you all again. But I won't do that quite yet. Oh, wait, I just discovered I can at least be able to see 5 of you at a time. So, does anyone have any questions or thoughts or anything you wish I would have gone into more depth with?
Thank you so much. There was a request in the chat if you could share the pocket card.
And it's truly a trifold sort of, heavy stock pocket card. I can't share it with you electronically, but we have good quantities through some very generous Office of Rural Health funding and the Geriatric Scholars Program through the VA. I will just go back really quickly here. Julie Moore is our 3D card contact person. She's an awesome nurse educator that I work with. And all you have to do is email her, tell her how many you want, and give her an address that the post office could deliver to. And or no, sorry, no PO boxes. That's the rule with that.
Wonderful. Thank you.